Could I have the introduction slides, please? It's my pleasure to introduce Dr. Brent James. Dr. James will speak on health care in the new world, quality as a core business strategy. Emerging priorities for healthcare delivery in the new millennium are safety, quality, and value. And value's been defined as outcome per unit cost. So those who pay for healthcare and those who seek healthcare will seek value to achieve the best outcome at the lowest cost, which is a segue into Dr. James' lecture. He's an international expert on quality improvement. He's a member of the National Academy of Science, Institute of Medicine, and he contributed to the major monographs that propose re-engineering healthcare delivery in the United States. He has academic appointments at the University of Utah and at the Harvard School of Public Health, as well as the University of Sydney School of Public Health. He's a Chief Quality Officer and Executive Director for the Institute of Healthcare Delivery Research at Intermountain Healthcare. He's Director of the Advanced Training Program in Clinical Practice, and he's lectured and trained over 3,500 physicians and many more nurses and administrative executives in the areas of quality improvement, which create cultural changes at their respective institutions as they relate to quality and safety. So it's my pleasure to introduce Dr. James. So I've been privileged to hear Dr. James lecture several times, and he's an amazing speaker. And I would have to say he had a major impact on me because I became very interested in quality as it pertains to head and neck cancer care after participating in our clinical safety and effectiveness course led by Dr. James.
Thank you, Randal.
Thank you.
Good morning. Around 1900, the healing professions went through a massive transformation. Our professional progenitors did four main things. First, following the Flexner Report, they completely reformed medical education. To become a licensed physician, the course of education increased from about a 4-month training period to 2 years, done in hospitals at a patient's bedside. They changed licensing. That new educational standard meant that you had to actually know something to claim to be a physician or nurse. The biggest by far, though, they formally adopted the scientific method as a basis for how we know what we know. And finally, number 4, they gave us our current organizational structure for care delivery, not just here in North America, but around the world. It was really the science piece, though, that made the difference. How we know what we know put the healing professions on a fundamentally new course. Massive improvements of our understanding of the human organism in health and disease. Huge gains in patient outcomes. It's easy to make the case that we routinely achieve miracles in care delivery today. Perhaps the best illustration, a child born here in North America in 1900 had a life expectancy of about 49 years. A child born 100 years later, 77 years. We fundamentally redefined what it meant to be a human being. This change is attributable to the healing professions. A more recent set of examples, the #1 killer in any modern industrialized nation is ischemic heart disease. Since 1960, the age-adjusted mortality for that condition has declined by more than 56%, from about 307 deaths per 100,000 per year to 135. The second most common cause of death is cancer. I couldn't figure out how to put it onto my slide. It's really a series of diseases. I'd need several slides to illustrate the principle, but you see the same effect. Number 3, killer stroke, one of our most profound improvements, 70% decline in age-adjusted mortality from that condition. The main point that I want to make to start the conversation, People alive in modern democracies today have better health and better health care than any previous generation of people living on the planet. And it's an easy point to make on the evidence. That's not what you hear from governments, though. In the United States, in Europe, in Canada, almost constant refrain of criticism that healthcare is broken, that somehow we fall short. Well, the problem that dogs a politician is budgets and payments for medical services. Just as one example, the key issue in the United States is something called the fiscal gap. All modern governments face it, though. It's the difference between their income and their promised outgo to the people within a society. In the United States in 2008, for people alive in that year, Medicare program alone, that difference was about $38 trillion. The shortfall between the promises and the reality. Social Security, pensions as people age, shortfall there is $7.7 trillion in 2008. Well, when you summarize it in the United States, the budgetary shortfall for the United States federal government is minimum about $60 trillion. That's the most conservative estimate I've been able to find. Probably a much more accurate estimate is roughly twice that, 120 trillion. To put that in perspective, the present value of the United States of America, all public and private, intellectual and physical property, our homes, our cars, this building, everything together in the United States, about 70 trillion. Technically, the government of the United States is bankrupt. I mean, not just morally, but financially. And this condition persists across essentially all modern democracies. This slide is intended to demonstrate the source of the problem. Do you notice that about 2/3 of the shortfall is healthcare? The major source of the problem is healthcare. As a direct consequence of this, we can accurately predict that payments for healthcare are going to fall. Payments for specific services in a hospital or in a clinic, budgets in Europe, budgets in Canada, budgets in Australia have to fall. There's a financial reality behind it. Now, we've established that healthcare today is the best the world has ever seen, but it turns out we fall short of our theoretic potential. That's the right way to think about this. You see, to say that healthcare is broken, you'd have to assume that somewhere along the line it actually worked in the manner desired. Think of it as the continued progress of the healing professions. The body of research that underlies this actually started to come together about 40 years ago, and it centers around variation analysis. Started in Great Britain in 1934 with a fellow named Glover looking at tonsillectomy rates. Perhaps the person who made it into a science, though, Jack Wenberg, Dartmouth University, the author of the Dartmouth Atlas, seminal article published in 1973 in the journal Science. What he showed was after carefully adjusting for population factors, massive variation from one locale to another in the rates at which specific treatments were applied. The problem was that the variation was so large that it was pretty much physically impossible that all patients, even with full access to care, were receiving good care. Deeply professionally troubling. The next 3 items on my slide are really specific examples of variation. Perhaps the lead author around inappropriate care was Bob Brook, Chief Medical Officer at Rand in Los Angeles, a senior professor of internal medicine at UCLA. A fairly large literature, though, for some treatments routinely delivered in American hospitals, as much as 32% of all care delivered judged to be clinically inappropriate, where the risk of the treatment to the patient outweighed any potential benefit. Should never have been undertaken, but it was. In fact, within this literature, the major studies range from 2 to 32% inappropriate. No one's done a careful synthesis across the entire house of medicine. rough guess, being familiar with that literature, but only a guess, about 15 to 20% of all care delivered is clinically inappropriate. Number 3 item on the list, November 30th, 1999, the Institute of Medicine's Committee on Quality of Healthcare in America published a report called "To Err is Human." You're probably familiar with that report. That's where we estimated that somewhere between about 44,000 and 98,000 Americans die each year, where the cause of death were preventable injury sustained as part of healthcare delivery just in hospitals. It means that in the United States, at least, hospitals are somewhere between the 4th and 6th most common cause of preventable death. And this one kind of has karmic balance. You have to love this one. The idea of a hospital is a major public health problem, because technically we are. Now, the truth is my name's on the report. We did a careful evidence review, found about 60 major studies showing this phenomenon. Believe it or not, we were trying to be conservative, and subsequent research has shown that we were. Now, let's keep it in perspective. Any treatment powerful enough to heal can also harm. You're often walking a very thin line between help and harm. And in fact, that's the argument that the profession gave to us after we published the report. On net, we achieve a world of good, 3.5 to 7 years of additional life for every member of U.S. society, directly traceable to care delivery. People saw this as just the price we had to pay for this manifest and large good that we routinely achieve. You see, think of it this way: the gods of clinical science are hungry gods, and they demand a blood sacrifice for the good that we achieve. And those hearses leaving our hospital with these unfortunate accidents are just the price we have to pay for this large amount of good that we do achieve. The problem is those people didn't read the second half of the report. It turns out that you can achieve the same good without paying the price, that there are methods by which you can massively reduce the injury rates if you approach care delivery the right way. That was the point. Not really a criticism of current care delivery. It achieves a lot of good as an opportunity to be much better. Item number 4 on the list. Turns out that in some areas we have hard evidence of benefit for specific treatments. Perhaps the best study, again in a fairly large literature, Beth McGlynn at Rand, examined when we have good evidence of benefit, how often we execute correctly, how often we do the things that we know work. This tended to be subjects that were non-controversial, very long established, solid evidence of benefit. Beth showed that we do it correctly in adults about 55% of the time. We do it correctly in children about 46% of the time. It's a failure of execution. The care delivery system fails to execute. Now, 2 other things you need to know about this whole body of research, this massive body of research. The first is most of the work was actually done in the United States. We tend to invest much more heavily in research on average than other countries. However, such evidence as we have from other countries, from Canada, from countries in Europe, from Australia, from Singapore, shows exactly the same effect. Small differences in type and tenor, but the same general effect. This is a set of opportunities offered to all modern societies. We could be better, is what it tells us. You see, the second interesting thing about it, around 1900, we adopted the scientific method and saw massive change, huge benefit come of it. But we applied it in a very interesting way. Over here, we had new science, understanding the human condition, developing new treatments, and we apply it rigorously. A meeting like this, the talk we just heard, a demonstration of that science, repeated thousands of times each year across the profession. On the other side, though, was care delivery. And we treated care delivery in a very different way. We just assumed because we were ethical individuals, very, very highly trained experts in our own right, that because we were quality individuals, our care delivery was quality as well. What this body of research really represents is taking those measurement methods we learned from science about the human condition and applying that same scientific approach to our performance as care deliverers. So when I say we fall short of our theoretic potential, it's against that standard. You know, this is really the history of the healing professions, though. Each generation is required to take the next step ahead. And this is one of the steps that are required of us. The reason when we started to apply the same science to care delivery, we found massive opportunities to improve, to be much better in what we do for patients in their hour of greatest need when they come to us seeking our help. Well, the next thing you need to know, we've been able to show significant improvements. Could I get you to advance my slides in the back? My remote has decided to stop working. Next slide. There we go. The fifth thing on the list, if you apply those methods I've just been describing of science to clinical practice, it turns out that a very great deal of what we do is non-value adding from a patient's perspective. There's a particular theoretic structure for it. My favorite one comes from W. Edwards Deming, the father of quality improvement theory. A few years ago, Dr. Lucy Savitz and I got a little grant from HRQ to do exactly that. We built a 6-part model. We had national estimates for only 2 of the 6 parts. The other 4 were non-trivial. Just from those 2, we estimated that more than half of all expenditures for healthcare delivery in the United States are technically waste from a patient's perspective. Well, that's half of a $3 trillion budget this year. When President Obama, speaking of the United States, says that the key to the United States economy is healthcare, he is technically correct. The same is true in Europe. The same is true in Canada. Huge upside opportunity to do well financially by doing well clinically is the fundamental idea. A rough estimate, more than 80% of all those cost savings arise in clinical medicine, not in administrative services within the healthcare sector. The next thing that you need to know, next slide please. The year was 1991. The setting was LDS Hospital, Intermountain Healthcare's flagship in Salt Lake City. The lead scientist was Dr. Alan Morris. Dr. Morris had been studying a particular condition called acute respiratory distress syndrome. We usually manage it using a mechanical ventilator in an ICU. A group of Italians had developed an artificial lung called ECOR, extracorporeal CO2 removal, to treat these patients. The technology was promising. We were seeing widespread adoption across the United States, despite the lack of any evidence that the new treatment actually worked, the artificial lung actually worked. We obtained a grant from National Heart, Lung, Blood Institute to test this new therapy, so we were putting together a randomized controlled trial. Treatment arm, the new Italian artificial lung, ECOR. Control arm, standard ventilator management of this condition in the ICU. We thought for the first time to look for variations in ventilator settings. We were familiar with this literature showing variation in many aspects of practice. Interestingly, in a long series of trials around ARDS, no one had examined this question. There was just an assumption that expert pulmonologists delivered care in a consistent way. When we carefully examined ventilator settings for ARDS, what we discovered was massive variation. We were able not just to show variation from physician to physician, expert intensivist to expert intensivist in the ICU, we were actually able to show significant variation, same attending physician, same patient, morning to night rounds. Well, in the body of science around clinical trials, we know how to deal with variation. It's a key study design factor, isn't it? If I don't deliver the care in my trials in a consistent way, I can't tell if differences in patient outcomes are due to the treatment, causally linked to the treatment, or hopelessly biased by the variation in treatment from inconsistent arms in the trial. The way that we've controlled that is with protocols in the arms of a trial. Therefore, we knew that we needed to create a protocol for ventilating settings in the control arm of the trial. It took about a year to develop a careful evidence-based best practice protocol for ventilator settings for acute respiratory distress syndrome. Interestingly, naivete, we assumed that we could just go to the literature and find the right answers. Our experience, though, was typical for the body of medical science. We could find evidence in the literature for best treatment about 20% of the time. That's if we accepted an evidentiary standard of expert consensus opinion in a published form. Level 1 evidence, of course, is randomized controlled trial. Level 2 evidence is strong observational designs, case control studies, quasi-experiments. Level 3 is expert consensus using formal methods in a published form. Even at that level, we could find evidence for best practice only about 20% of the time. This is typical on average across the face of medicine, just in passing. For most of what we do, there is no evidence about what's best for a patient. We were therefore forced to rely upon expert consensus. Dr. Morris did it right. He involved intensivists from around the United States, major academic centers, and from Europe. He ended up with probably the best evidence-based best practice protocol I've seen in my life. Thorough, if nothing else. The finished document was a flow chart about 40 pages long. It averaged over 20 decision nodes per page. More than 840 explicit recommendations on how you set a ventilator based upon a patient's physiologic presentation. Well, the next insight, we realized that we did not know whether that protocol represented best care. Next slide, please. Next again, and one more. Thank you. Therefore, Dr. Morris chose to implement it in a very clever way. A book had come out the year before, written by a fellow named Womack. It was called The Machine That Changed the World. In it, he described an advancement in quality theory called lean. You've probably heard of lean. One of the key factors in lean is something called mass customization. With mass customization, you build a standard process, then you allow the workers in that process to vary based upon, well, in this case, individual patient need. For this to work correctly, you have to build in a measurement system that tracks every time an expert clinician wants to vary and then feeds the resulting data back to the group overseeing the protocol and does it in the context of a full set of intermediate and final patient outcomes. So it becomes what we call a learning system, where it tracks over time with the aim of learning. Now, in building those guidelines, you face some real challenges. I've already mentioned the first, lack of evidence for best practice. We have evidence for best practice only 15 to 20% of the time on average. Now, in some areas, it's much higher, 40 or 50% of the time. Pediatric oncology, for example, very high levels of evidence compared to most of medicine. Other areas, though, general pediatrics, very close to zero. Second problem, it turns out that expert consensus is unreliable. Experts can't accurately estimate rates using subjective recall. In my experience, doesn't work in these settings. What you get depends upon whom you invite. Invite different specialists, sometimes just different individuals, you'll get radically different guidelines about best practice. Maybe the most important, guidelines don't guide practice. There's a strong literature that shows that developing a guideline, training everyone in it, and then asking them to apply it, they'll all say that they change practice. It's just that the practice doesn't actually change. Well, in the context of Alan's trial, what he did was build that learning feedback loop. a very thorough evidence-based best practice guideline with an embedded system to track, number one, variances. Anytime somebody varied, we tracked it. And number two, patient context, short and long-term patient outcomes. What this slide shows is protocol compliance when they did that. They first tried it on patient number 29 in the series of ventilated ARDS patients they were tracking. In that patient, they followed guideline recommendations 41% of the time. More than half of the time, the physicians and nurses varied from the protocol. But then they started that little feedback loop running. In its first 4 months of operations across the first 8 patients, they put more than 125 changes into the guideline. Now, a side statement, but a very important one. This was probably the best evidence-based best practice guideline I've seen in my life, even to date, in terms of the care that went into its development, the rigorous evidence evaluations, the expert consensus methods used. That abstract document changed wholesale when it hit reality at a patient's bedside. This has been a common finding every time we've tried to use evidence-based best practice protocols. There's a difference between sitting in the conference room and talking about it and living it at a patient's bedside. And Dr. Morris's method addressed those differences. Yes, by patient number 8, we first went over 90% compliance with the guideline. Second major factor to observe. You'll note that there's not a single patient where they followed 100% of the guideline instructions. Well, it goes beyond that. This is now the heart of ARDSNet, a major academic research collaborative, multi-center trial collaborative, who continues to examine this problem decades later. All of them use this same protocol as a foundation for their work. We have literally thousands of patients through this protocol. To my knowledge, there is yet to be a single patient where they've been able to follow all of the guideline recommendations in a consistent way. Another way of saying it, I don't think you can write a guideline that perfectly fits any patient. The humans who come to us for care are just too different from one another. Different exposure to pathogens in the environment, different genetic factors, different response to those pathogens, different expression of disease, different response to treatments. Well, you layer on top of that differences in resources, personal preferences, and values. Easy case to make, you see. Well, in the context of the trial, we had some very interesting findings. The results, with application of this particular method, survival in ECMO entry criteria, ARDS patients increased from 9.5% to 44%. ARDS was first defined as a syndrome back in the 1960s. This was the first time since the syndrome was defined that anyone had shown an improvement in clinical outcomes. Interestingly, stabilized or standardized ventilator management performed much better than the artificial lung. So the actual results of the trial was to redirect us toward a standard approach to ventilator management. In parallel, hospital costs fell by about 25%, from about $160,000 per case to only $120,000 per case. And physician time to manage these complex patients fell by about 50%. Well, what we did was take Allen's successes and generalize the concept into what we call shared baselines. So here's the idea. You pick a high priority clinical process, you pull together a true team, you generate an evidence-based best practice guideline, understanding that they are never perfect, never completely correct. The next step, perhaps the most important, you blend it into the clinical flow of work using standard order sets, clinical flow sheets. Well, we have about 10 tools that we use to blend it into workflows. Your aim is to make it so that you don't have to rely upon expert memory. We know that if you rely upon memory, counting on physicians and nurses to correctly apply the protocol every time, you'll get about 50% performance on average. It's just too complex an environment in modern medicine for the expert mind to cover every small detail. You make it so that the default is the evidence-based best practice. Then I say it to my colleagues this way. Ladies and gentlemen, it's not just that we allow, or even that we encourage. We demand that you modify our evidence-based best practice protocol based upon individual patient needs. We know for a fact that with very rare exception, you can't write a protocol that perfectly fits any patient. That's why we have you. Your job is to modify it for individual patient needs. This has profound impacts on the clinical environment, as you might expect. Key takeaways: no protocol perfectly fits any patient. Well, you can overcome that using shared baseline bundles, as they're sometimes called. Number two, very serious limitations to protocol development. Well, you can overcome that by using a learning system that feeds the variation data back in the context of patient outcomes. Three, this reliance on human memory, even expert human memory, means that you'll execute very, very poorly. Well, solution: embed your protocols into workflows so it becomes the default, the lowest energy state. Just let it happen. You get evidence-based best practice. Take your most important resource, that trained expert mind, the physician, the nurse. Focus them on the relatively narrow band of activities where they can have a major impact on patient outcomes. Now, an interesting thing about this, I trained originally in surgical oncology. I got my experience with trial design. I worked at the Dana-Farber Cancer Institute for quite a number of years. I helped support the Eastern Cooperative Oncology Group, about 450 hospitals studying cancer treatments together. I was over GI tumors for quite a number of years. Between my residency and my experience in clinical trials, there is nothing new here, is the interesting thing. The same principles that made good trials, the same principles that made a good surgeon, this just represents a routine application, with one exception. Rather than me being an expert unto myself, saying in my experience, each colleague saying the same, we had to function as a team. Rather than each intensivist in the ICU having their own approach, we had our approach around which we varied. It's the craziest thing in quality theory. The key to effective variation is standardization. The same principle that drives good trial design. You create a standardized environment where you can systematically introduce variation change and measure the impact of that change. That principle applies just as well in daily clinical practice as it does in good science. And that's the point behind this whole thing, you see. Well, we've applied it very, very broadly. A recent one, this shows compliance with a sepsis bundle. The number one cause of preventable death in a hospital today in modern nations is usually sepsis. 20 to 50% of these patients die. We were specifically focused on patients entering our hospital through the ER with sepsis. This is more than half of the cases. With that bundle, we went from 25% compliance to up around 90 today. We were pretty good when we started, a 20% mortality rate, among the best in the country. In fact, I checked before I came, 6% across our 4 largest hospitals. We fundamentally redefined sepsis as a disease and its outcomes. Now, a takeaway from this, we count our successes in lives. Within Intermountain, a system of 23 hospitals, about 200 clinics, about 50% of care delivery in the Intermountain West, I can document more than 1,000 lives per year from applying these methods. People who would have died a few years ago and don't today. Because we were able to pull together as a team and standardize care in such a way that variation within that care became measurable and effective. We count our successes in lives. We have not yet begun to understand how good we can be for our patients in their hour of greatest need. The second thing, nearly always better care is cheaper care. That idea of waste in the system comes from the same model, you see. We've taken at least $250 million out of Intermountain's cost of operations. This is a massively remunerative experience. Now, just one last concept. It turns out that under current payment mechanisms, when you achieve these kinds of benefits, when you reduce your cost of operations, whether you're in Canada or in the United States, you're financially punished. it usually comes as windfall savings to purchasers, to insurers, or to governments. You have to have mechanisms to harvest some of those savings back. But I think that's our real future. Process management, quality improvement as a science of process management is really the key. Higher quality drives lower costs. Under developing forms of payment in the United States, capitation, and appropriate at-risk budgets in countries like Canada's hospital system, you can set it up so all of those savings come back to care providers. Now, most of the savings take the form of unused capacity. It's freeing up those doctors' time. It's freeing up the ICU beds. But we anticipate massive increases in demand as the baby boom enters chronic disease years, from really epidemiologic diseases like obesity, as technology continues to advance. We can create the capacity to deal with that increase in volume within the confines of our current system. It does require a major financial model shift, but perhaps most important, it takes a team. Now, as you look at these methods, remember one last thing. None of them are perfect. You could think of it as failing towards success. It's the mandate and opportunity for every generation within the profession to take the next step ahead. In this generation, we've come to understand that, yes, we continue to advance the science, but at the same time, we need to understand, well, the science of care delivery itself, the performance, the execution within our systems of care delivery. Just as our professional progenitors created a new era for medicine and a new future for humanity, the same lies before us. A wonderful opportunity. And with that, let me say thanks for your time and attention.
Thank you, Brent. Thank you, Brent, for a wonderful presentation. It was very inspiring. And thank you for sharing part of your vacation with us this week. So, thanks again. They'd like to get a picture here. Thank you. Are you leaving today?